Welcome to the American Journal of Psychiatry Residence Journal. I'm your host, Neil Christopher. On this episode, fourth-year medical student Cameron Kiani interviews Dr. Ken Gillman, one of the world's leading experts on MAOIs, the drug we often fail to prescribe. You can find his blog at psychotropical.com, along with links to all of his publications, videos, and other recordings. Let's get to the interview.
Dr. Gillman, why don't you tell me a little bit more about your background?
I did my training at Guy's Hospital in London, and very early on in my training, I worked for quite a long time doing research and clinical work on a rather unusual, almost unique unit, the Jeffrey Knight Psychosurgical Unit, which was, of course, part of the neurosurgery department. And that unit did the very specialized stereotactic tractotomies for serious treatment-resistant depression. And working in that unit, we took referrals from all over the UK and from abroad also. And that's why very early in my career, I got a great deal of experience dealing with unusually difficult cases of depression. And my boss used MAOIs very extensively, as one would if one was treating difficult cases of depression. So I learned how to use them before I really understood much about psychopharmacology at all. And fairly soon after qualifying, I decided it was a bit cold and damp in England and I wanted to try living in the tropics. And I came to Australia in 1983. I was in a relatively isolated situation in terms of academia and professional support and things like that, because Mackay's a regional town. It's 1,000 kilometres north of Brisbane, which would be the nearest major centre, really. Not a very major centre, really. And so I looked after the public hospital and ran my own private practice, and there was pretty much for much of the early phase of that 1983 onwards, the only specialist in town. So I had to learn to treat people effectively, and that meant using more and more MAOIs. The old expression, the proof of the pudding is in the eating. And so from very early in my career, I found myself using MAOIs sometimes as a first-line treatment.
I wanted to start by talking about sort of the history of MAOIs, because it's very closely tied to the history of psychiatry and also the history of psychopharmacology, specifically as it relates to depression. So would you be able to speak to the sort of rise and fall of MAOIs?
So what happened with MAOIs was they were, of course, the very earliest antidepressants to be discovered, even before tricyclics. And it all happened around 1960, plus or minus a couple of years. And in those days, of course, the pharmacological profile of many drugs simply wasn't known accurately. So half the drugs that were labeled as tricyclic antidepressants aren't really antidepressants. And some of the drugs that were very, very closely related, of course, that were labeled as antihistamines were actually antidepressants. And that was because they didn't have the technology and the techniques that we have now to assay more accurately what their receptor profiles were. Almost immediately, MAOIs came in, you had the tricyclics to be mixed with them, and of course people were so ecstatic about having drugs that actually worked in depression. Quite a lot of people started mixing things together without having a very thorough knowledge of the underlying pharmacology, and that was a recipe for trouble, and trouble they got in spades.
Yeah, the original MAOI was actually an anti-tuberculous drug, Icahn, correct?
Yes, absolutely. In fact, the very first ever case of serotonin toxicity was beautifully described from that unit. I think it was in New York State, where they trialed the isoniazid and iproniazid. And they gave a patient, it was actually a doctor, they gave him pethidine, and he got a classic serotonin syndrome, serotonin toxicity, as we prefer to call it now. So those things happened because they didn't understand about tyramine in cheese. And so when reactions started to happen, everybody got quite apprehensive about it, understandably. And in fact, as you may know, the American authorities actually withdrew MAOIs from the market. They weren't withdrawn in most other countries, certainly not in the UK. And it took a year or two before the dust settled a bit and people began to understand a little bit about tyramine. When, by the time the dust had settled and people had decided you shouldn't give too much cheese because of tyramine and so on, the tricyclics had started to become much more widely used and seemed to be just as effective for many people and much safer. And so MAOIs just kind of started a downward slide. There was a little bit of self-interest, I suppose one might characterize it as, in terms of as more and more new drugs became available and a whole series of tricyclic type antidepressant drugs did the rounds before the latest generation of the serotonin reuptake inhibitors came in at the end of the 1980s. And that meant that they were trying to sell those drugs. And of course, the drug companies had a lot of influence and money and presence. And so that meant inevitably they tended to emphasize the greater efficacy and especially safety of these newer drugs. And that almost inevitably meant exaggerating the difficulties of other drugs. That's what competition is, isn't it? You pump your own side up and you make out the other side isn't so good. But in terms of general usage, they fell to a fraction of 1% of the total antidepressant scripts that were issued.
Let's talk about actual pharmacology now. So what are MAOIs? How do they work?
Well, the monoamine oxidase enzyme is responsible for metabolizing serotonin, noradrenaline, dopamine, and other neuroactive substances as well. But those three are the ones that we've concentrated on for the last 5 decades, more or less. And if you block monoamine oxidase, you reduce the rate of breakdown of those substances, and so their concentration is greater. Not their concentration in the actual synapse itself initially, because of course monoamine oxidase is an intracellular enzyme, but it means that greater amounts of those neurotransmitters are released into the synapse as a result of a nerve impulse. So their fundamental action is to increase the amount of the neurotransmitter that's released in all of those three pathways.
As you've pointed out, with the mechanism of MAOIs is that it's a completely different mechanism. Is that significant?
Yes, highly significant in my opinion. The paper I published in Biological Psychiatry was actually aimed at elucidating a lot of these mechanisms. What we understand is that there are 3 main mechanisms which can substantially alter levels of neurotransmitters. And that's blocking monoamine oxidase, the other main mechanism that you've just said, which is blocking the reuptake mechanism, whether it's for serotonin or noradrenaline or dopamine. And the third mechanism is releasers, MDMA, ecstasy, which causes a release of the synaptic stores of serotonin. There are other drugs like tetrabenazine and the other new drugs that cause release of dopamine primarily. And then, of course, the epinephrine-type drugs that can cause a release of noradrenaline. And those mechanisms can produce substantial changes in the levels of neurotransmission and therefore be toxic. So understanding the interactions between those 3 basic mechanisms and their propensity to raise or lower the toxicity of different combinations of drugs is, in my submission, one of the really important and fundamental ways of improving your understanding of much of psychopharmacology. In fact, it was so important that when I did that review, I think it was the CNS Spectrums one, the whole business of methylene blue and how we discovered that it was in fact a potent monoamine oxidase inhibitor and could be responsible for serotonin toxicity. When I wrote that up as a sort of review after a year or two after that had been discovered, I invented, if you like, a thing called the serotonin toxicity triangle, which was a triangular diagram, obviously, with those 3 classes of drugs we've just mentioned at the apices of the triangle. And that helps people to picture and understand the interactions between the two. Because, for instance, a releaser like MDMA, tyramine, of course, is also a releaser. That's why it's useful to understand this. Has to get into the presynaptic nerve before it can release anything. How does it do that? Well, it doesn't just passively diffuse into the cell. There's an active mechanism to take it up into the cell. And you don't get any prizes, of course, for guessing what that mechanism is. It's the serotonin reuptake pump for MDMA, and it's the noradrenaline reuptake pump for tyramine and other indirectly acting drugs like that. So if you take a serotonin reuptake inhibitor before you take your ecstasy, you actually block or diminish, attenuate its effect. And if you take a fully effective dose, a large dose of a serotonin reuptake inhibitor, you'll more or less stop ecstasy or any other similar drug having any effect. And exactly the same thing can be hypothesized, if you like, or actually there's quite a lot of evidence to show that it is definitely so. So it can be shown that the same thing applies to the noradrenaline mechanism. So tyramine is blocked from getting into the presynaptic nerve and causing the hypertensive reaction if you take a potent noradrenaline reuptake inhibitor. So that's an attenuation of the mechanism, those two mechanisms. But on the other hand, if you look at serotonin reuptake and an MAOI together, you get a massive potentiation of the effect. So you only have to take a relatively small dose of a potent serotonin reuptake inhibitor and you die of serotonin toxicity. And I really do mean that. I mean, of all of the things that you can do with psychotropic drugs, mixing an MAOI in a fully effective therapeutic dose with a serotonin reuptake inhibitor in a fully effective therapeutic dose is predictably unlikely to cause significant serotonin toxicity, which frequently will be fatal if it's not dealt with properly. So that's quite a spectacular interaction. You really only get fatal serotonin toxicity with that mixture of interfering with the two mechanisms at the same time, i.e. monoamine oxidase and serotonin reuptake. If you only block serotonin reuptake by itself, no matter how potent the drug is, there's a ceiling to how high serotonin will go. And if it's only a serotonin reuptake inhibitor, the ceiling effect means people's temperature won't go above 38.5. They might get a bit of clonus and a bit of hyperreflexia and stuff, but they're not going to basically need intensive care treatment or be in danger of dying. But mixed with an MAOI, you've got a serious problem. So if you look at the propensity of different tricyclic antidepressants to be implicated in that combined reaction with MAOIs, then you see that drugs like amitriptyline, nortriptyline simply don't do it. It doesn't matter how much of them you take in combination with MAOI, you don't get the slightest twinge of serotonin side effects or serotonin. And that was because only one or two of the tricyclics are actually clinically significant serotonin reuptake inhibitors. Now, that's an important point to make because most of the standard texts say that tricyclics are dual reuptake inhibitors. That's simply not correct. It's only clomipramine and imipramine which have significant potency as serotonin reuptake inhibitors. And that's the explanation of why it's actually safe to mix tricyclic antidepressants with MAOIs. And that was one of the huge problems of the 60s and 70s. People just didn't understand why these toxic reactions were occurring. Sometimes they even confused hypertensive episodes with serotonin toxicity, and so on and so on. So chaos reigned, and because so few people understood the underlying pharmacology, the whole thing was shrouded in myth and misconception for decades, basically. And that's why it's so interesting. So I guess what I would say to your listeners is that I think one of the most exciting things about understanding this is if you understand this and these mechanisms, then you almost immediately understand 75% of all the psychopharmacology you need to know.
Dr. Gillman, I have two questions. What are the practical realities of prescribing MAOIs? And how has the lack of popularity and reduction in use affected our medical training?
I think that's a very important and a very good question. What was the statistic or the figure that I saw a little while ago that pharmaceutical companies spend more on advertising in 1 week than all the medical schools in North America cost to run in a whole year? That may surprise some people, but irrespective of whether that's accurate or not, it's certainly in the right scale and ballpark. And I think when you realize that covertly or overtly, a very great deal of what you're exposed to is ultimately determined by the drug companies. You know, journals have to make a profit, and a vast majority of their profit comes from publishing papers that are managed by writing agencies and funded by drug companies with the objective, of course, of making their product seem more favorable and selling better. So it's a huge influence that can't be ignored. And that meant that the whole basis of training and the prominence of different ideas in the intellectual space just got altered. And MAOIs got pushed more and more to one side. And you'll find, and my international expert group really reinforces this, that a huge proportion of doctors have had either none or very poor education in this field. And therefore, to a substantial extent, you've got a situation where we have a serious danger of the blind leading the blind. If the doctors in their 40s and 50s and 60s who are training the younger doctors haven't really got much experience of them, how can they do the training? So that's one of the main reasons I started the International MAOI Experts Group, was to help improve education and awareness and knowledge about these drugs. And that statement that we made, that was published in Professor Stephen Stahl's journal, CNS Spectrums, only a matter of some few weeks ago, was a sort of, if you like, position statement that was co-signed by about 80 international specialists about the poor education and information concerning these drugs and how it was appropriate to look carefully at that and try and do something about it. Can I return to the question that was asked before about the practicalities of actually administering it? The practical aspects of it, I think, are encapsulated by the simple precepts of good clinical pharmacology. And that is start low, go slow, and only change one drug at a time. I must say I'm sometimes somewhat dismayed by the cases that come across my desk of how people have had their drugs changed so frequently and several drugs changed all at the same time. That's just not good clinical medicine. What does start low and go slow mean? Let's stick to talking about tranylcypromide at the moment. That means 10 to 20 milligrams a day. It seems very clear from the relatively small amount of data we've got, like how much you need to inhibit platelet monoamine oxidase, which is an in vivo assay, if you like, of whether the drug's being effective. But there isn't, sadly, much data on that. People gave up doing it very early on and got distracted to things that were better remunerated, I think. But if I was dealing with a healthy adult, I'd start with 20 milligrams a day. Now, the full therapeutic effect in terms of blockade of monoamine oxidase as reflected by platelet monoamine oxidase inhibition and blood pressure, that's what reminded me of this. MAOIs lower blood pressure. Everybody seems to think they raise blood pressure. They don't. MAOIs were actually used by the cardiologists as antihypertensive drugs in the 60s because they lower blood pressure. We still don't understand the mechanism exactly behind that, which is very interesting, but they do. Obviously, they soon went out of use for that purpose because at that time, lots of new drugs were coming on the market and they were much safer. But nevertheless, that illustrates the point that they are hypotensive drugs. They reduce blood pressure. And that's a pretty reliable indication of whether they've reached a therapeutic level. So the first piece of practical advice is monitor the blood pressure sitting and standing of all of the patients that you see. And obviously, it's a good idea to have a reliable baseline measurement before you start treatment. So you use the degree of postural hypotension as a guide. It's not the be-all and end-all, but it's the best guide we've got because, of course, you can't routinely measure platelet monoamine oxidase inhibition. I mean, it's physically possible to, but no laboratory that I know of in Europe or North America does it. It was only used as an experimental technique. We used to do it in London. But it's never been used clinically because MAOIs fell out of fashion before people really got into gear doing that sort of thing. So we've really only got the degree of postural hypotension as a guide. And obviously, one of the practical side effects of these drugs as you start them is people can get faint and dizzy, fall over and hurt themselves. So that's a jolly good reason for making sure that you go slow and steady and you keep an eye on the blood pressure. And if you know how much the blood pressure is dropping, or not dropping, but if you know how much it's dropping, then that gives you a good deal of confidence to know whether it's safe to push the dose up a bit more or whether you should wait a bit longer, and so on and so on. So that's almost a linchpin of a guide as to how to start MAOIs. So what I would do is start with 20, and if after a week there's no sign of postural hypotension at all, you do 2 standing measurements, and if they're not dropping at all, then you push it up to 30. Because as a general guide, I would say that between 30 and 60 milligrams a day covers a great majority of people who are going to respond to MAOIs.
There is also a phenomenon where patients will have sort of post-dose hypertension. What is the mechanism of this? And is it something that needs to be managed pharmacologically?
Quick answer to that is not usually. Nobody knows the mechanism. It's another of these fascinating mysteries and another area where some more research would be very good. And remember I said that a bit of a hobby horse of mine is measuring people's blood pressure regularly. But sadly, because in the history of the use of these drugs, so few people have actually done that, the data that's been accumulated on, for instance, how frequent this transient post-dose hypertension that's usually half an hour to 2 hours after the dose, especially a single larger dose. So it's definitely related to the blood level of the drug, because just to remind people who aren't aware of this, the half-life of tranexaminase is really very short indeed, around 2 hours plus or minus. So it's not usually something to worry about, but if it's clinically a problem, then you can use a beta blocker to reduce it. Some people have talked about using nifedipine to reduce it, but I'm very strongly against that.
So this hypertension that we're talking, this post-dose hypertension, this is different from the tyramine-induced hypertensive crisis.
Yes, of course, yes.
How is tyramine formed? And why is it less of a concern now than it was, let's say, 30, 40 years ago?
Yes, that's fairly easy to answer. It's formed by the decarboxylation of tyrosine, which is one of the amino acids that makes up all proteins. It's not normally present in anything other than trace quantities, unless microorganisms of one sort or another, and they might be fungi or bacteria or whatever, unless they act on protein sources that contain significant concentrations of tyrosine, decarboxylate it and turn it into tyramine. Now, generally speaking, that only happens to the extent of it accumulating to significant concentrations for our considerations when foods are deliberately subjected to a process of fermentation or aging involving microorganisms. So that might be cheese, it might be soy sauce, it might be fermented salami, sausages, etc., etc. So that doesn't necessarily mean, those processes of fermentation, etc., doesn't necessarily mean that it's going to accumulate, the tyramine is going to accumulate to high levels, because, and this is perhaps one of the main factors relating to generally lower tyramine levels now than in decades gone by, many of these production processes now use engineered starter cultures, and in fact some of them are even genetically engineered now, but deliberately produced starter cultures for these processes which don't contain microorganisms with the capacity to decarboxylate tyrosine, and therefore tyramine hardly accumulates at all. Obviously, that's not universal, but because food hygiene has been such a big thing in Western countries in the last 30 years for all sorts of different reasons, that process has become much more ubiquitous, much more prominent. Also, of course, the general hygienic handling of things like meat and all the rest of it has become much more rigid to do with import-export controls and control of bacteria and all these kinds of things. So, for instance, almost all meat processing in civilized countries is now legally obliged to be done at 4 degrees centigrade or less. You can't just slaughter animals in a shed and chuck it in a packet and sell it. You know, it's got to be done at less than 4 degrees. So any contamination is much less likely to, proliferate, as it were, and cause the formation of tyramine. But of course, that's only where the supply chain is regulated in a organized society. Obviously, in other countries and societies, it may not be quite so organized, and therefore you might have to be a little bit more careful. But what that means in general is that all the standard food sources that we, if you like, are all likely to come across have much less tyramine in them than they used to. And what a lot of doctors don't realize, because most of this research is not published in the medical, PubMed type journals, it's published in the food science journals. There's a wealth of information about biogenic amines in just about everything you can imagine. And obviously that includes tyramine. There's a wealth of information about that now, and that's what's in the extensive monograph that's on my website, and that paper I published in the Journal of Neural Transmission a year or two ago. And as a result of that, what we can say fairly confidently is the levels of tyramine that were measured by Blackwell and the classic work like that back in the 60s, there were 3,000 milligrams per kilogram of tyramine. Massive concentrations. Most cheeses now, you'd be lucky if they've got 300 milligrams per kilogram. So really, you're really looking at an order of magnitude difference in a vast majority of the foods that people are likely to consume in terms of the level of tyramine in the end product. And because the reaction is a dose response thing, you can't suddenly get massive hypertension from taking 5 milligrams of tyramine. And you've got to have 100 milligrams to get a really serious reaction. So because it's a dose-related response, we can say fairly confidently that a vast majority of people who get a little bit of excess tyramine are not going to have anything much more than a relatively transient increase in blood pressure up to a couple of hundred or 250 maybe, that lasts 1 to 2 hours. And that's unlikely to cause any major problems.
Can you speak to the sort of co-administration of releasers with MAOIs?
I think my quick answer would be that it's perhaps not appropriate to describe it as safe to co-administer them, but depending on the circumstances, it's not absolutely contraindicated, because, of course, again, it's a dose effect relationship. And if you lower the dose appropriately, a lot of these drugs that are available aren't actually very potent releasers. I don't have the figures in my head right at the moment, but they're relatively weak releasers. And in reality, one dose of them, especially if it's a nasal spray or something, is extremely unlikely to even cause a measurable elevation of blood pressure.
So how restrictive is the diet actually? I know that's usually a big concern amongst patients, and maybe why prescribers aren't prescribing these medications, because they think the diet is too restrictive. Is it very restrictive?
Well, let me answer that from a patient point of view. I get lots of communications from patients that say, it's so easy, what's all the fuss about? That's a common response. I don't often get communications from people who say, look, this is terribly difficult, I can't cope with it, and I keep getting a high blood pressure. Obviously, there are some people who aren't very good at understanding and managing these kinds of things, just as there are people who aren't very good at taking their insulin properly or taking their anti-epilepsy pills properly or whatever. That's real life and that's medicine. But, sensible patients who are well educated find it quite easy to cope with it. Looking at it from my point of view, if you like, what I say to people is that, look, at the end of the day, if you have a normal diet and you eat sensibly and you don't eat, a half a kilogram of chocolate or a kilogram of beefsteak that's been aged or whatever, if you have a relatively normal diet in sensible dietary helping, proportions and helpings, there's almost nothing that you can't eat. Because, for instance, mature cheeses, everybody can't eat mature cheese. Like I just said, the figures from all that work that I've condensed into that monograph show that almost no matured cheeses now have a tyramine level of more than 300 per kilogram. So that means that 100 grams has only got 30 milligrams of tyramine in it. Now, 100 grams of cheese is an excessively large portion. 25 to 50 grams is a proper portion. So that puts things in perspective a bit. So, of course, you can raise your blood pressure if you go silly and have huge helpings and get a bit unlucky. But what it means for a great majority of people who eat sensibly is there really isn't much change they have to make. Obviously, and I keep emphasizing this because I keep getting asked to produce a table or a list for people about what they should and shouldn't eat. My answer is, well, of course, it's not quite that simple. People need to understand a bit about it, and different people take different attitudes towards risk. Everybody has a different illness experience of how severe it's been and how much problem it's caused in their life and their marriage and their work and all these kinds of things. And so the degree of risk that different people might choose to take is going to be different. Yeah?
Right. I'm curious, in your career, how many patients have you treated with an MAOI?
If I just change the wording of that question slightly to how many patients have I cared for who have been treated with MAOIs, it must be close to a couple of thousand. If you change the question to how many patients have I taken direct first-hand responsibility for all of their care for when treating them with MAOIs, the figure would probably be closer to 1,000.
Well, that's getting close to all the time we have for today's episode. Thank you so much, Cameron, and thank you, Dr. Gillman.
Yeah.
Please follow the links in the show notes to psychotropical.com, where you can learn all about the expert group and all the articles referenced in this episode.
We can always look at having further discussion at such time as proves convenient.